Hello, everyone. Welcome to UCL. Welcome to the Faculty of Medical Sciences public lecture series. My name is Dr. Neftali Marina Gonzalez. I'm an associate professor in the Division of Medicine. I'm the host of the public lecture series, and it is my great privilege to bring you today's speaker. The title of the talk today is How UCL Revolutionized Prostate Cancer Diagnosis and Treatment for Men Across the World. And our speaker is Professor Mark Emberton. He's a professor of Intervention Oncology and Dean of the Faculty of Medical Sciences. So he is basically also a consultant urologist at University College London Hospital's NHS Trust. His academic work has been fundamental in developing diagnostic strategies and new therapies for men with prostate cancer. And he was also the founding pioneer of the charity Prostate Cancer UK. So it is my great privilege to introduce Professor Emberton. Please type your questions in the chat. At the end, we're going to have a questions and answers session. I will read some of your questions, and then we will discuss the topic further. So, Professor Emberton, thank you very much for joining us today, and please, it's all yours.
Great. Well, thank you very much, Neff. It's a real pleasure to be here. Let's see. And hopefully you can see my first slide. So this is a very bold and arrogant title, deliberately so to provoke a little bit. But I'm the first to acknowledge and realize that actually when there is innovation and development, it's very rare that there is only one group doing it. And the evolution of diagnostic change in the last 10 years was certainly led by UCL, but there were other groups around the world doing it at the same time. And I think we've seen that with the COVID-19 vaccines. So the messenger RNA vaccine, we had one result from one group and then another result very similar from another group about a week or two later, acknowledging that actually good ideas tend to happen roughly at the same time, and they happened amongst different groups across the world where the right conditions arise. So the title's deliberately bold, but I'm not claiming exclusivity. But I think, well, it's for you to determine. I think we've contributed significantly to improving the diagnostic pathway and the treatment pathway for men across the world. And so why did we do that? Well, there were a lot of problems with the old pathway. Most of you listening to this are too young to worry about prostate cancer. But what's interesting about prostate cancer is that most of us will develop it as we get older. I have about a 30% chance of having prostate cancer cells in my prostate, but that doesn't make me worry because most of us will die with prostate cancer rather than die of it. And some of you may have heard that phrase before. And so the problem with the diagnostic methodology that we had in the past was that we used to miss important prostate cancer. We used to misdiagnose important prostate cancer. We used to overdiagnose. Now, that's a difficult concept to understand. So that's identifying a disease that, if left alone and unrecognized, would not have affected that individual during their remaining life. And overdiagnosis can result in overtreatment, which means that men undergo treatment and the harm associated with it without any benefit. And if you're not benefiting from a treatment, all you do is incur cost and convey harm to the individual, which is not good. So there were lots of reasons to try and get this right. And the way to getting it right was to come up with a diagnostic pathway that identified clinically important disease. In other words, the kind of prostate cancer that, if left untreated and undiagnosed, would result in a reduction in the quality or quantity of life. And this was our goal right at the beginning. And this is really a story about the invisible becoming visible. For about 100 years now, and the first radical treatment for prostate cancer was done at Johns Hopkins University in Baltimore about exactly 100 years ago. And for most of those 100 years, we were treating disease that we couldn't see. And so we could only really identify it down the microscope. And obviously, it's very difficult to treat anything if you can't see it. And if you think about the way that most cancers are diagnosed these days, it's largely through either imaging or a symptom resulting in an X-ray or a CT scan or indeed an MRI. For instance, a bad cough or producing blood might result in a chest X-ray or a CT scan of the chest to identify early lung cancer. But that first identification of the disease is done through imaging. With prostate cancer, it wasn't like that until very, very recently. And we follow in others' footsteps who sought to bring forward the invisible to the invisible by use of technology. And here you can see Galileo, the development of the X-ray, and here a young soldier trying to hear oncoming airplanes before they could be seen. And of course, there's a long history of this. Radar is a really good example of it, and you can see that before radar, you had to have spotters to actually see the planes coming at you. With radar, you could see what was hitherto invisible. And actually, we've used some of the techniques that radar used to identify whether or not we had a way of detecting disease, or in this case, bombers accurately. And this is the receiver operated characteristic curve that you can see here. And this was developed to see if radar operators were any good or not, whether they declared a hit or a miss. In other words, whether they correctly identified an incoming plane. And they used this to quantify just how good a radar operator was. And it's interesting that today we use exactly the same statistics to tell whether our diagnostic strategies are good in identifying a hit versus a miss. So this is to give you some insight into how good or how bad we are or were at identifying prostate cancer. This is a salami slice through a man's pelvis. And this is the first attempt we had of trying to image prostate cancer using magnetic resonance imaging. And this is the type of imaging many of you will have had, actually. If you break a bone or have an injury, often an MRI is the first way of evaluating it. And I won't spend too long on this because you can barely make out the prostate, yet alone the prostate cancer. And basically, just to orientate you, because you're going to see some more images like this, this is a man with the head into the screen and the feet out, and he is lying on his back, and we are salami slicing through his pelvis. But actually, just to say that you can barely make out the prostate. Some of you will have spotted this midline structure here. I'm just showing it to you with the arrow with the rectum behind. That's the prostate, but you couldn't possibly make out a prostate cancer. So that was 1982, at a time when MRI was thought only to have a role as an investigational scientific tool. Nobody anticipated that this would be in routine use today. So a few years later, we're now to 2005, when we started using MRI to try and identify prostate cancer in patients. And here we have the prostate in close-up now. And what you can see here in outline, so I'm outlining the outline of the prostate. This bit is the prostate that the man was born with. This bit in the middle is the bit that's developed since the man was a teenager. And that's the bit that grows over the years and makes the prostate bigger. Some of you will have already spotted that there is distinct asymmetry here, and that you can see that there is an abnormality on the right-hand side of the prostate. That's a prostate cancer. You wouldn't be able to feel that with a finger. Typically, the way to identify prostate cancer was to place a finger in the rectum. The rectum sits just behind the prostate, but you would be very hard pressed, or you'd have to press very hard to identify any changes in the prostate on the right-hand side. It's only through imaging that you get any idea that cancer is present, and more importantly, where indeed it is. If we now come to 2014, and this is an illustration of the extraordinary technological change that we've been seeing during my working life, and that we've been able to kind of use to help diagnose men. So here we see exquisite detail. This is an older man. This is a much bigger prostate. This is the hip joint here. Hip joints are about 50 cc's in volume. This prostate's about 80 or 90 cc's, which is big. So that's about the size of a small orange. And here you can see the transition zone, which is occupying most of the prostate. Remember, this is the new growth of the prostate that is starting to make the prostate bigger. And behind, we can see the part of the prostate that the man was born with. This is the older part of the prostate, and this is where cancers develop, because essentially there's more time for the genetic mutations to occur and to build up. Other structures that who are interested in anatomy, you can just see the bottom of the bladder there and the rectum behind, and others will have identified many other structures. So this is a kind of similar specification MRI identifying a prostate cancer, which this time is in the midline, and we can see it identified there. This is just one sequence from MRI, and here we can see about a 0.3 cc tumor, which has a triangular configuration, sits just behind the urethra. So this is the area through which a man passes urine. And here we can see the cancer position there. This is probably identifiable with a finger if it's big enough actually to reveal a lump to a very sensitive digit. So, and obviously, if you can't see the cancer, and remember, until very recently, you could not, because we didn't have the benefits of imaging, all you had was a random interrogation of the prostate. So men had needles directed into the prostate without knowledge of where the cancer was. And you can imagine that that was a pretty hit and miss affair. So the needles were placed through the rectum. You could see where the prostate was, but you couldn't see where the cancer was. And so they were distributed in a fairly random manner on the left and the right-hand side of the prostate, without any real knowledge of where the cancer was. And here you can see that just by chance, the cancer was hit, but only one component of the cancer that gives you only one component of the story. And so this man was identified as having low-risk prostate cancer. These were the low-risk cells in green, and typically we would watch that when in fact, you and I know, because we can see the truth, that he had a mixture of high-risk cells and low-risk cells. If the biopsy plan was repeated without knowledge of where the cancer was, and time has passed and the cancer had grown, on a subsequent distribution of needles, and this is called a systematic biopsy, you might indeed, just through chance, say that no cancer was detected, and so you might then stand on the original diagnosis, even though the number of aggressive cells have increased. Imagine a new world, and you've seen this picture already, where you could do a test, an MRI in this instance, and identify an abnormality in the right, what we call the anterior horn of the prostate. And again, you can see it there. Well, it's not beyond the wit of man then to identify that and direct needles to it. This is another view of the prostate. Once you have the images, you can manipulate them in a number of ways. And this is a man standing up now. The bladder is above, and the urethra you can see here. And there's the left-hand side of the prostate and the right-hand side. The same tumor is seen here in the right lateral aspect of the prostate. And so if you know all that, it's not too difficult to imagine where the cancer is on your ultrasound, because that's what we use to do the biopsies, and direct your needles straight into the tumor and get good representative sampling of the tumor, so you don't make a risk stratification mistake. In other words, you don't tell the man that he's got disease that he doesn't have. And if you have accurate information about the cancer that the individual has, you can make an accurate decision on treatment, and you're more likely to offer this man appropriate treatment. Now, MRI is just one form of imaging. That is the imaging, as I'll illustrate in just a second, that has transformed the pathway for these individuals. We've gone from random chance to great precision, but actually there are many types of imaging that we can use, and they all generate slightly different results. And the reason is that they all turn positive on different biology and different attributes of the cancer. And it may well be that in the future we will use an array of imaging to give us a profile of what the nature of the underlying cancer is. And we might not even need to put needles in it to kind of verify its nature or its grade, in other words, how aggressive it is. And here I'm using something called PSMA PET. This is a PET scan that uses an antibody tracer. And I'm combining 4 different cases with MRI. They all had prostate cancer, and you can see the pathology specimens in front of you, and they are the pink illustrations. But here's a man who was PSMA positive and MRI positive, so you could see the cancer on both sets of images. This individual was PSMA positive and MRI negative, so his MRI was wrongly negative. This was a false negative and a true positive on the PSMA. Here we see a PSMA negative and an MRI positive. So here the PSMA scan was wrong. That was a false negative, which is quite rare with PSMA, but can happen. And here, dear oh dear, no diagnostic investigation is perfect. We've got a PSMA negative and an MRI negative scan. This prostate cancer was a bit smaller, so maybe was a little bit below the threshold of detection, and in retrospect could have been identified. But it just shows that all diagnostic tests have their limitations. And it may be that in the future, hyper-augmented ultrasound or state-of-the-art ultrasound will have a role in addition to PSMA and MRI in identifying people with true disease. So, as you can imagine, over the years, we were of the view that there was a huge role for MRI in helping the pathway, but the challenge was to prove it. And for many, many years, we were using MRI, but the rest of the world did not believe that it worked. And I think it's quite fair to say that they thought we were making up the data. And so it was critical that we conduct a study that was sufficiently robust and of sufficient scale and sufficiently representative. So in other words, was done in centres other than our own to prove to the world that there was a role for MRI. And this was the study that was published in The Lancet now 3 years ago. And what we did was compare MRI, the new fancy test that not many people believed in, versus the standard test, which was the standard random biopsy of the prostate, against a reference standard, a super duper test, which involved interrogating the prostate every 5 millimeters. And that was like playing battleships with the prostate. And that was the ground truth, that we compared the old test with the new test. And the results are available for you to see. You can download this paper for free. Showed that the MRI was 100% better, twice as good as the existing standard test in identifying men with clinically important disease. And that was really the game changer that made the world sit up and acknowledge that MRI had an important role. But it's interesting, in changing practice, sometimes you need a little bit more evidence than that. This was a perfect diagnostic test in which all men had 3 tests: old-fashioned biopsy, brand new MRI, and the reference test, the basically playing battleships on the prostate. The patients who took part in this study deserve great credit and great recognition, because they underwent a huge number of biopsies in order to help us validate whether MRI would have a role. And it was their sacrifice, really, because they didn't really benefit directly from it in taking part in the study, and nearly 600 men did, that allowed us to take things forward. And the results of this study, this caused huge waves throughout the world and made the skeptics sit up, but actually not change their mind. And often in medicine, to change people's minds, you need a randomized study. Now, many of you will know what that is, but that involves randomly allocating the new method of diagnosis versus the old method of diagnosis. And there were quite a few people doing this, and this is testimony to that good ideas are seldom truly original, but they are quietly developed in different parts of the world by different groups. The world is a relatively small place, so we keep in touch with people. And these were the studies that randomized MRI and targeted biopsy versus the standard alone. And as in all clinical studies, they weren't all positive. These were the positive ones. These were the studies that said that MRI was better. The other studies said that they were roughly the same. And of course, that depends on the patients that you include, the design of the study, the quality of your MRI, the quality of all your histology. But nevertheless, there were no negative studies. The trouble with all these studies, and the reason they didn't change practice, apart from the one at the bottom, which is ours, and I'm going to tell you a bit more about that, is that they were all single center studies. So they basically all described the experience in their own center. And doctors are skeptical. And you've heard skeptical commentators on the vaccine. Oh, we need to see the results. Oh, we need to see the safety data. Oh, we need to see more research. And that same response was given throughout the world. And it was really this study that was published about a year later that really clinched it and made it possible for all men in the world to insist upon having an MRI before biopsy. And this is a multi-center randomized study run out of UCL. It was led by Viru, who's the first author on the paper, who's a trainee working with us right now. And you can see Caroline Moore, the senior author at the bottom, and my name next to her. And here is a list of names, and there are many others that were instrumental in making this study happen. And rather amazingly, it showed that MRI prior to biopsy resulted in fewer significant cancers missed. That's the error you really don't want to make when treating any cancer. You don't want to tell a man he is all clear when he is not. Also, there were fewer insignificant cancers diagnosed. I talked about overdiagnosis earlier. It's a difficult concept, but an important one. And we were less likely to tell a man he had disease that wasn't going to have any consequence for his remaining life. And that's a good thing. We halved that rate from 20% to 10%. The MRI resulted in fewer men biopsied. If you had a normal MRI, you didn't need a biopsy. So about 250,000 men a year would be able to avoid a biopsy in Europe if the results were implemented. There were fewer needle deployments. In America, each needle that you deploy costs $100 to process. The pathology was more representative, as I showed you in that illustration. There was less harm to the patients because fewer were biopsied, fewer needles, and therefore fewer side effects. And importantly, less cost. And we managed to show in a subsequent study, which used these data, that MRI was the most cost-effective strategy. That doesn't mean it was the cheapest. It does mean that for every pound spent, you identified more men with clinically significant disease, or missed less men with clinically significant disease compared to the alternative. And this is called a frontier detection plot, showing the most cost-effective studies right at the frontier. And all the blobs that you can see are MRI-related studies. So it was this is a huge amount of work over a long period, and lots of patients saying, yes, I'd like to take part in your study, for NICE, the National Institutes of Care Excellence, in the spring of last year, of 2019, to insist that MRI be offered to all men prior to a biopsy, as you can see it there, and consider not doing a biopsy if the MRI was normal. Which is still difficult for a lot of urologists to accept, because after all, we don't stick a needle in an organ if the imaging is normal. You don't do that in the brain or the liver or the lung, and the prostate, as always, is the last one to catch up, but we think that we are there. What we're working on now is to try to make MRI more democratic, more available, cheaper, easier to interpret. And MRI of the prostate is about the hardest imaging that is available to us, because, as I showed you earlier, the prostate sits behind the bone in the pelvis. It sits in front of air or solid matter, in other words, the rectum, and it sits behind a lake of fluid, which is the bladder. And in imaging terms, those juxtapositions are very, very challenging. And so we have to use multiple sequences to give us a summative bit of information that tells us whether cancer is present or not. And these are the sequences that we use on MRI. The cancer, for those of you that haven't spotted it, is in the right peripheral zone. You can see it there, dark on T2, bright on this diffusion weighted scan, bright on this scan that measures the movement of blood. In other words, the perfusion of the prostate. Cancers have more blood supply than other areas. And here you can see dark on this, what we call the ADC map. The most complicated sequence is giving some contrast to the patient and then taking lots of pictures over time to see where the blood goes and identify the cancer in that way. And that's the dynamic scan that you can see here, what we call the DCE. And I suppose the question is, if we drop that, that requires a doctor to be present, it requires a drug to be given, it requires about 20 minutes of scan acquisition. If we could get rid of that, the scan time would go from about 35 minutes to about 15 minutes. So instead of 1.8 patients per hour, you could suddenly do 4 per hour. And actually, because you don't need a doctor, you're not administering drugs, you could do the scan supermarket if the supermarket wanted it and patients wanted to have there, because it would be a purely passive acquisition. Remember, MRI doesn't convey any X-rays. There's no radiation associated with it. And so this is the research question that we're currently addressing. I can't give you an answer to it now because we've just received funding to do it, but we have a design to do it. And hopefully, if we show that the shorter scan is better than, or sorry, equivalent to the longer scan, we can offer it to more people at less cost and less harm. And there's quite a lot of evidence to suggest that this might indeed be the case. And some people are offering the 2-part scan rather than the 3-part scan. But the evidence is, although compelling, fairly scanty in terms of that it's all retrospective. It's not based on the kind of prospective studies that were required to get MRI into the scene. And we could do this either with a randomized trial, which obviously was important in getting MRI in. That would need a lot of men. So that would need about 3,000 men, which we think is probably going to be prohibitive, both in terms of time and cost, or 300 men if we do a rather kind of clever study using patients as their own control. And what that would mean is that we would do all the sequences on a man and then analyze 2 sequences. So some individual would just have 2 sequences available to them to declare abnormalities within the prostate. And somebody would analyze the whole sequence to identify abnormalities in the prostate from the 3-sequence scan. So here in blue, you can see an abnormality from the 3 sequences. Here you can see an abnormality identified from the 2-sequence scan. And here you can see abnormalities that both identified. In other words, they were shared rather than private. And so we can calculate the relative worth of the simple short scan in green versus the complicated long scan in blue, and identify just how we might use it in the future. And hopefully that study will start recruiting soon, and that will mean that MRI will be available to many more men around the world. And particularly we're concerned about resource poor environments where MRI is too expensive and too complicated. The other thing we're doing at the moment is trying to do better with the sequences that we've got. And again, here brings in the extraordinary might of UCL. So computer science is able to kind of analyze the results that we generate with MRI and interrogate the images in the way that the eye cannot. And this is something that we call verdict MRI. And this creates a kind of map of the prostate and any abnormal signal within it. And you use algorithms or artificial intelligence to help you declare where the cancer is. And here you can see that in the colored picture there, identifying an abnormality without a human being needing to do so. And this is clearly the future and the way we're going to go. And in fact, so good is artificial intelligence and algorithms now that it allows us to make inferences about the underlying disease in the prostate, and actually can allow us to differentiate between low-risk disease that would typically require us to put a needle in and look at with a microscope versus high-risk disease, which wasn't possible with the naked eye. In the future, and we're starting to do this at UCL, this is probably the most expensive fridge in the world. It's called a hyperpolarized MRI. And this allows us to identify cancer based on how it consumes energy. So this isn't looking for structural differences. So we're not looking at the shape of the tumor or the morphology of the tumor. We're looking at the way tumor behaves. And again, using this machine, and it's a very expensive machine, a very complicated way of doing it, we can actually declare the presence of prostate cancer by the way in which it metabolizes sugar, essentially, to create energy. And cancer cells are very good at doing that. And that's how they thrive, and that's how they divide. And hopefully in the future, we'll be able to identify them in a non-invasive manner by the manner in which they do that. The study that is recruiting today, that I'm leading with a large number of individuals, is hoping to really future-proof this and to try and integrate all the information we have on the individual in front of us, the prostate within the individual, and the cancer within that prostate. And we are seeking to integrate imaging with all the genomics that we can get from the individual and the cancer, from blood, from urine, and also from the background information we have on the individual, the kind of drugs they have, their family history, etc., and integrate all this to create a new model of progression so that we can much better identify men who have truly low-risk cancer, or men that have the type of cancer that is likely to progress and therefore will need treatment. And this is an amazing study because it's brought together a large number of groups from all over the world, so academic groups that you'll recognize there, artificial intelligence groups that are analyzing the data that we've got, and biomarker groups, some of which you will possibly have heard of. Now, doing research and hopefully listening to this are many of the researchers of the future, and we look forward to welcoming you at UCL if you decide to come here, and hopefully you'll be doing this kind of work. But this is just to illustrate how challenging this has become. This is the recruitment curve of Reimagine, and just shows you that things happen. And we started the study a little bit late, but we're slowly catching up. And the star is the onset of the lockdown at COVID-19 in the spring of 2020. And obviously, all non-COVID-19s were halted because it was dangerous to be in hospitals at that stage. There was obviously hospitals were geared to accept patients who were seriously ill. And in order to do that, participants in study were told not to come to hospital, and therefore we had to close the study. You can see that we just managed to maintain some recruitment during most of the lockdown and then again over the summer. And you can see that it's slowly picking up as we're now able to open more centres, and we hopefully will be able to recruit closely on time. This is another study, this is the other part of Reimagine, in which we are less reliant on patients attending hospital, in which we are using MRI to screen men who are not patients. They are patients out there minding their own business, with being perfectly healthy, and we're inviting them to come for a prostate check. And you can see here that had COVID not happened, we would have recruited to this study by now. Because these individuals weren't patients, this was the first study we closed down because we wanted to protect them. We then had a long discussion with our patient panel that are involved in the study, and they gave us some very good advice in order to restart this. And they said we should offer taxis to men because obviously coming to hospital on public transport may add risk to them. And we took their advice and we created a video and some information sheets that they could have as well. And you can see that on starting the study, the recruitment rates are virtually identical, if not greater than they were before. and it looks as though we're going to recruit well ahead of study. So well ahead of what we predicted. So this is a really good example of being ready to deal with problems when doing research. There are lots of problems that one encounters and one has to troubleshoot, but also of the importance of working with patients and participants and allowing them to solve your problems by giving you a patient perspective. We shared this with the funders, the MRC, today, and they thought this was just a fantastic example of working with patient participants and want us to publish this as a case story. But I think it's a really good piece of news, but does show just how delicate the situation is in terms of patient recruitment. So the pathway's changed. It is now very, very different. If your GP tells you, I think you're at risk of prostate cancer, I think you need to see a urologist, we have a much more sophisticated, safe and accurate way of managing these patients. And I think this is due to all the developments that we have had the privilege of leading. Now, obviously, if you know where the cancer is, you can do a lot more than just diagnose. You can treat better, because you can direct your treatment away from the prostate and towards the cancer. So you can do better surgery, you can direct your radiotherapy to the cancer, and you might indeed be able to treat the cancer alone and preserve the prostate and therefore preserve function. And that's really important because by treating the prostate, many men are at risk of incontinence, in other words, leaking urine, requiring a pad, and also of sexual dysfunction, not being able to get and maintain erections. When we started this out, everybody thought we were mad. Again, just showing some of the challenges of early research, that all ideas at the beginning look a little bit crazy. You've got to, get reassurance that they aren't crazy, and with time build confidence into them. And actually that's through data. And and from the last slide to this slide is only a couple of years, and you can see that funding agencies are very quick to recognize, well procured data and willing to regard this as a celebration rather than a threat to health. So a lot of research is hard hat territory. You've obviously got to be sensible, you've got to be safety critical and very responsible. But actually some of the time you have to persist with your idea and provide the evidence to change practice. But it's still tricky. And you won't know this, Patrick Walsh is probably the most eminent urologist. I grew up, he was the guru and actually made a huge difference to the whole field of urology. In fact, I went to visit him before I became a consultant, but he wasn't happy. And he said about me and our study and our team, it's disappointing that a Lancet journal would permit the authors to conclude that these patients were actually free of disease, and for the authors to fool the public into believing it. So, so that was quite hard to take. I gather he's come around now, although he's never written to me to say that, but he is a really strong advocate of imaging. And so to finish now, I'm just going to take you through a image-guided treatment. I'm going to take you through a patient that had treatment that was driven by MRI, and then we'll stop and take questions. And obviously, before you do anything in research, you find out what's known about the subject. And this is a systematic review that one of our visiting fellows from Switzerland did for us several years ago. And that really set the scene for us to be able to treat in a tissue-selective manner using MRI to do that. And let me take you through it. So you're all experts now on imaging. This is an MRI of the prostate. Spot the cancer. Yes, you're all right. It's that thing sitting up there at 1 o'clock that you can see there. This is the T2 sequence. Remember, the cancer's dark on this sequence. It's bright on the gadolinium, so this has got a big blood supply. The cancer cells are hungry for oxygen and glucose and make their own blood supply. That blood supply is different from the natural blood supply. We can tell the difference with imaging. We can see that the movement of water is restricted in cancer. There are lots of cells, and therefore the movement of water is restricted. And we can see that here. And we can see that in this inverse image of that. You can see it there. This is called the long B diffusion picture. This is a cancer in the left anterior part of the prostate. This would have been missed by digital examination, by standard biopsy, because of where it is. It proved to be cancer because we knew where it was. It was a cancer of moderate risk, but definitely needed treating. And it was confined to the prostate and therefore curable. There's the cancer. So we've gone through the diagnostic phase. That took us 10 years to get there. You've just seen it in a few seconds. This is the treatment phase. I've not said too much about this, but once you know where the cancer is, it's really easy to surround it with some needles. And you can see that here, and you can see it here, exaggerated a bit, magnified. And this is what I do most weeks of the year. And I surround the cancer with needles, and we pass high voltage electricity in the order of 2000 volts, which generates about 30 amps and blows holes in the cell membrane in order to destroy the cancer cells and push them into programmed cell death. So this is the bit, you can see it happening. We do this in theatre with a patient under anaesthetic as a day case procedure. And this is the result that we get. This is an MRI. So MRI to diagnose, MRI to treat, MRI to check that we've treated adequately. And here we can see the prostate a week later with an absence of blood supply to that area, the cancer, and this is essentially dead tissue that will slowly form a scar. And we can see that scar 6 months out. And actually, it's very difficult to tell that this man has been treated. His PSA, for those of you that are alert, has gone down from 6.6 to 1.7. That's a blood marker that we use for prostate cancer. 1.7 is normal for this individual. And we can see that the abnormal signals disappeared on that long B scan that you can see here. This is a scan to show you that this treatment, we've managed to preserve the key structures, which is why this man was continent and had normal sexual function. And he kept his urethra, really important for continence. That's the sphincter that keeps you dry. He kept his bladder neck, that contracts during ejaculation to force semen into the outside world. And he kept his blood supply to his prostate, which is the nerves that supply the process of erection and detumescence. And this is just to show you that actually in our studies, if you have this focal treatment, you keep your erections. They drop a bit just after treatment because you have needles put in your prostate, but they recover very well. This doesn't happen after surgery. And you can see that here in another depiction of erectile function. This is using patients to score their own functional status before and after treatment. So very, very little impact on the patients. And so not only has MRI improved the diagnostic pathway, it's given us a whole new way of treating men with prostate cancer who previously only had two options. One was to do nothing and keep an eye on it and preserve their function. The other was to have their prostate removed or irradiated and sacrifice either sexual function or continence. And today, the difference we've made is to provide a middle ground, so-called focal therapy, which has been enabled and created by MRI. And with that, I just want to thank everybody involved in this work. It's been a fantastic opportunity and a great privilege to be able to do it. And we've been the beneficiaries of lots of grants and lots of charities that have helped us get there, and lots of people over the years. Some of them have moved on and are running programs themselves around the world. Some of them are here, and I'm sure I've left some people out, as this is a slightly old slide. So thank you to all those involved in research, and thank you to all the patients that have taken part in our studies. We are truly eternally indebted to you, as are all the beneficiaries of these diagnostic process and treatments. And thank you all to you for giving up your time and listening to this work from UCL today. Thank you.
Thank you very much, Professor Emberton. That was truly inspiring and absolutely amazing work you guys have been doing in UCL. And I really hope this will inspire the new generations of scientists we have here. We have approximately 500 attendees, which is a really huge number, considering this is after school hours. So thank you all for joining us. We have a few questions. I actually rank them according to all the attendees can actually vote. So I'm just gonna ask you the most probably popular questions. And the most popular definitely was related to COVID. How do you think coronavirus has impacted the treatment? So obviously you showed us the impact on your recruitment of patients for the studies, but how did it impact the treatment and diagnosis of patients with cancer?
So it did to a huge extent, and I think that was made fairly public by well, in the media. CR UK obviously had many communications reassuring patients to present if they had symptoms. In prostate in London, we had a patient died actually very soon after surgery who got COVID-19, and obviously this was before we knew very much about COVID-19. This was kind of in March, and obviously we were really worried that you know, this individual was recovering from surgery, and this happened in London. They got COVID-19 3 or 4 weeks after surgery and died. Now they may have died anyway, but we didn't know that at the time, and we didn't know if there was any interaction. Surgery does knock your immune system. We've known that for a long time, and clearly it makes you vulnerable to a bit of pneumonia, to clotting, etc. And we know that COVID is involved in both those activities. And we were very, very scared and very worried that actually if you did a surgical procedure and the individual got COVID afterwards, that they were at huge risk. Now, that was the only case, but that was with a background where you know, I think you have to think back how frightened we were about this disease that we didn't really understand. Mm-hmm. And clearly, you know, not just men with prostate cancer, but you know, if people had blood in their stool or blood in their urine or blood on coughing, they perhaps didn't go to their GP and therefore didn't get referred, and therefore we didn't see them. And so that clearly happened, and we noticed that referral rates went down significantly, you know, during the acute, so March, April, May. I think that's recovered now. And what's interesting now is that the recruitment rates in the study, which kind of tests everything. Study is a very artificial thing, but it gives you numbers. So we've got a very similar acceptance rate now for the study than we had before COVID. So so I think it was very worrying, and obviously we did a lot of work over the summer to catch up with a lot of the operating that we stopped for 4 weeks actually during the peak, because all the anaesthetists, all the resource was actually going towards ITU. So I think it was very scary for lots of people, and it did impact on health. I think this time we can be, you know, second wave. I think we can be a lot more reassured that patients with symptoms are indeed presenting.
Yeah, that's true. I think we're better prepared, definitely. Next question, a bit more basic. What is a rectal exam used for the diagnosis of prostate cancer? So,
good question. So a lot of jokes are made about this. I think Billy Connolly famously, you can find that on YouTube, has made a kind of joke or a sketch out of it. Because the prostate is situated just in front of the rectum, you can put your finger inside the rectum and feel the back of the prostate, which is where we thought most prostate cancers occurred. But of course, we thought that was the case because that's what we could feel. And therefore, it was the men with cancer in the posterior aspect of the prostate that were diagnosed. And therefore, that reinforced our prejudice. So it just shows, and with MRI, there are as many cancers in the front part of the prostate that are missed. So what we used to do, actually we do it less now because MRI is so much better, is so you place a gloved hand, which you lubricate into the prostate, and you look for symmetry in the prostate. And cancer typically is hard and presents itself as a nodule that you can feel. And once you felt it, it's unmissable. The trouble is with prostates is that every man's prostate is different. So you can identify, I work with a radiologist called Claire Allen, who I can identify an individual through their prostate because a prostate is like a fingerprint. And that makes it very, very hard to have a notion of normality. Whereas every liver looks the same. every brain looks the same. You can't, Einstein's brain and Neff's brain are the same. You can't tell the difference between the two, but their prostates are very different, and you could identify them differently. So it makes the challenge really, really difficult. So the rectal exam, whilst useful historically, now has much less utility.
Yeah, that's very true. How does the growing of the prostate over time affect functions nearby, such as urination?
Very good question. It's interesting that not many things grow as you age. And the kind of joke is that earlobes get bigger and noses get bigger. But actually, most organs atrophy. In other words, they shrink and get smaller with age. And you'll see that in your elderly relatives. They get smaller. Everything shrinks except the prostate. We don't know why it occurs. And the kind of hypothesis is something called embryonic reawakening. And so the growth factors that were in play when these men were in utero, when they were embryos, that was making the prostate grow, are somehow switched on again. We don't know the mechanism by which that happens. It could be inflammation or hormonal trigger. Nobody really quite knows, but we know that these these growth factors do increase because they've been identified, and they encourage this benign, i.e. non-cancerous, slightly uncontrolled growth of the prostate, which we called benign prostatic hyperplasia. And what it happens is it grows the prostate, but squeezes the urethra. So the river runs through it. So the urethra runs through the middle of the prostate, and the more tissue you have there, because the capsule of the prostate is quite tight, the pressure increases, and therefore the force that the bladder has to generate to empty gets greater as the man ages. Now, at the same time, the bladder gets weaker as a man ages because it becomes a little bit more fibrous. And obviously you have those two things happening as you go from 60 to 70, etc., etc. Mobility gets less, the kidneys are less able to concentrate urine at night. And so you have this perfect storm where men suddenly have to get up 3 times at night. The bladder doesn't empty because the bladder doesn't generate enough force to empty the bladder. So the bladder is always half full, and therefore the capacity is diminished. And therefore they have frequency and urgency and hesitancy and poor flow. These are the symptoms they present with, and are more liable to get infection. And so in the past, people died of BPH, and they died of sepsis. And the prostate would grow, they would block off the bladder, the back pressure would go to the kidneys, and the kidneys would stop working. And we used to admit, Neff will remember these patients, we used to admit people with end-stage kidney failure that was due to benign prostatic hyperplasia. We used to catheterize them, but by the time we did that, sorry, that's placing a tube in the bladder, but by the time we did that, the kidneys were shot and the patients had nowhere to go. So it was a lethal condition in the past. It isn't today.
Yeah, that's really good to know. So, this question is really interesting. Has the amount of people with the cancer increased over the years, or would you say that more people are being diagnosed? And if so, why would be the reason for the increase?
Really good question. So prostate cancer is increasing with age, so it's increasing, but the reason is that men are living longer. And so all cancer, not all, nearly all cancer increases with age. Some unusual pediatric cancers have the inverse, but most cancers increase with age because we accumulate genetic mutations. And prostate cancer perhaps is, close to some of the lymphomas maybe, that is the cancer that's most, or maybe skin cancer, that is most associated with age. So, if men aren't dying of heart disease because they never smoked or stopped smoking, they're on their lipids and their blood pressure is being controlled, it's prostate cancer and dementia that are the two diseases that become prominent. Obviously, if you die at 60 or 70 because of a cardiac issue or lung cancer or something like that, then prostate cancer is really not an issue. So as men age well, And as their life expectancy increases, the proportion of patients that are going to have clinically significant prostate cancer has increased. And these men might live long enough for the cancers to grow and develop and spread. And once a cancer has spread, it becomes incurable. And you start needing hormones, you put on weight, increases your blood pressure, you develop breasts, affects your concentration, you can't do the crossword quite as well, and chemotherapy with all its attendant problems. And so treating older men who are fit is something that these new technologies can do. So it has increased in incidence and prevalence because of aging. Whether there's anything else that is happening in the world, you know, obesity being an important one. So prostate cancer is associated with kind of wealthy nations. Prostate cancer is less common in South Asia and Southeast Asia. So in other words, diet, you know, body mass index, lifestyle, vitamin D, all these things may have a role. We haven't really identified which is the key one yet. There's not much you can do to prevent getting prostate cancer, but we know that all these things have a role. So I suspect that the true incidence of prostate cancer in the West is going up for all the reasons I've suggested. So we know some of this from, you know, men who migrate to America, who have a low risk prevalence in one generation, and you know they end up in you know San Francisco or Detroit, and their children have kind of a risk that approximates the background prevalence. So these migration studies prove that it's not just genes that that are associated with the onset of prostate cancer. I hope that helps a bit.
Yeah, absolutely. I think that's really true. I think we have time only for one last question, and this one I find personally very interesting. I have a lot of interest in artificial intelligence, and I was absolutely impressed to see your data. It's absolutely beautiful. So, somebody is asking, by using AI to identify prostate cancer tumors, what will happen if it creates a mistake? Is there room for it to make a mistake, seeming that it could affect the patient's life? So this is a really big, obviously, ethical problem in the future. Especially artificial intelligence is one of the big scientific breakthroughs. So what do you think about that?
So this is almost a philosophical question about the role of AI and human beings. What's interesting about AI is that in most studies, it's not AI versus the human. You know, if you look at the best chest algorithms, it's humans working with AI that generates the best outcomes. And you know, humans can make kind of inferential leaps that AI cannot currently make. And that's not to say that AI won't be able to do it in the future. But at the moment, I think AI is going to be used to assist in the diagnosis, to make humans better. And take away a lot of the routine work out, so they can stay alert to the key elements that the human brain is good at doing. And I think that's a really interesting area of research in AI. In other words, you know, what do humans do well and what do machines do well? And you know, at the moment we're using AI to draw around the prostate and to draw around areas of interest and to kind of highlight bits for the radiologist. And then to get rid of a lot of the repetitive aspects of reporting, and I think that's working really, really well. Mm-hmm. There will never be a perfect test, you know, and we're using, all of us are involved in AI where the algorithms are not giving us the perfect result, you know, in life, and that's just something I think we need to accept. But I think for the moment, the challenge is to get machines and humans to work really well together, so we get the best outcome.
That's true. To facilitate the work of the clinician, not really just to make everything for them. Okay, it's near 6 p.m. So all is left for us to thank you on behalf of all the attendees. Professor Emberton, thank you very much for this amazing talk. I really think, I hope all our attendees are going to be really inspired, and hopefully will be able to join us in one of the amazing undergraduate programs we have in the Faculty of Medical Sciences, and probably become the next generation that will tackle such an important medical problem like prostate cancer. So on behalf of everyone here, thank you very much for your talk, Professor Emberton, and thank everyone for joining us today, and hopefully we'll see you in the next round of the public lecture series. Thank you very much, and I'll see you soon.
Great opportunity. Thank you very much.
Thank you.